So it's such a pleasure to be here today. Jordan and I are going to try and present in a way that we've never done before, and we've never done this together before either. So we'll see if it works out well. Hopefully it does. And I just want to say the main reason why we've come out here is because at Sick Kids in our emergency department, part of our strategic mission for delivering high quality pediatric healthcare is involving physician assistants as part of our healthcare strategy. And so with that, when I was speaking with Jordan, Claire, Julia, and Emma, our four current physician assistants working with us in the emergency department, we thought about, well, if we're going to sit down and do training sessions together, maybe there'll be other PAs sort of across the country, maybe even including in the US, that would also be interested in joining us. And so that's what PACE is. PACE is our physician assistant clinical education platform that we've built out online. There's a flipped classroom part of that we'll sort of demo for you later. And then there's also live webcasts that we'll be doing in this fashion here. So this is our sort of first live PACE session that we're doing. So we're super excited to launch this here. And we'll see how it goes.
Yeah. So this is not going to be like the presentations that you had earlier in the day. I want everybody to look at the people who are at the table with them. If you don't know who's at the table with you, shake hands, introduce yourself, because you're now part of a medical team amongst yourselves.
You're part of your medical team.
This is interactive participation.
Are you taping for them?
If you're sitting alone, go find a friend.
It may not be advantageous to sit by yourself.
Alright, so this is going to be a safe environment. There are wrong answers, but we're all here to learn together, okay?
Alright, so why don't we just jump right into it, okay? So the main objectives of this session, one, to introduce the PACE web sort of session that we're going to be launching soon. Two, to teach you something in pediatric emergency medicine, but more importantly, to sort of walk you through some of the decisions that our physician assistants are making in our department, and sort of that mentality of how we go about making these decisions in a very collaborative environment. So we're going to try and mimic that here a little bit. And I want you to imagine that you're coming into work at Sick Kids. This is the front doors of where we go in. You know, it's a semi-busy day. You've got some kids getting some care. There's a resuscitation ongoing related to a trauma that you walk past. And you get to the board and you see that there's 4 patients for you to pick up on your board. So I'm going to put this out to the audience. These are 4 totally different patients. Based on what you choose today, we're going to go down a totally different presentation. So this table here, why don't you pick which room would you like to go into today? So they're all green, which means their CTAS scores are all about the same. And let's just say that their length of stay in the department so far is about equal. 14. 14, I love that, that's my favorite number. Okay, so you go into room 14 and you've got Hannah, okay? This is her triage note, so you haven't quite gone into the room yet. Her vital signs appear normal, so her heart rate is 98. Her rest rate is 28. She's maybe gonna spike a fever, 37.8. She's 15 years old, and she's coming to the emergency department with her mother, who says she's been feeling much more anxious over the past few days. She feels sweaty, and her heart feels like it's racing. So her mom says that she has this past history of anxiety, and you know, you sort of get this impression from the nurse that this is, you know, she's having a panic attack, or she's probably just needs a bit of time. The nurse doesn't seem too concerned about this racing heart. The nurse does, though, document that she seems diaphoretic. She's got a bit of tachypnea. Her CAPA refill is normal. So you guys get to decide what you want to do. Do you want to go meet Hannah and take a history? Do you want to do a physical exam? Do you want to order a CT scan on her right now? Whatever you decide to do will happen. So what do you guys want to do? What's next? You want to take a history? Okay. So this is Hannah here. This is kind of what she looks like. She has 10 days of feeling a little bit unwell, increasing fatigue, and this throat pain, which I actually currently have as well. She feels a little bit feverish, but no one has measured her temperature. She's here today because of this racing heart. She's been really sweaty, and she has this chest tightness that's persistent. The mom seems a little unimpressed and almost a little bit annoyed that she's there. She says that Hannah's had these situations in the past, that she's had these problems with anxiety, and so she's not overly engaged, but Hannah looks a bit concerned about the way she's feeling. Her vitals are as documented there. And you note from the end of the bed that she is a bit diaphoretic, so like sweaty, but she's sitting up and she doesn't really look toxic. And she's got a nice palette, or a nice sort of color to her. Yeah. So what's next? What do you guys think about this so far?
What's your thoughts? What's next?
Yeah, so there's something probably
So-
going on with her.
So Devin, there's actually an ER response in the trauma room right now.
Oh, Hannah's got away, actually.
Hang on.
Okay, can you go and take care of that?
Yeah, no problem.
Okay, Jordan's gonna go to the trauma and sort out what's going on there.
So let's go to the recess room. We walk into the recess room and we are seeing a 6-month-old male. He's looking unwell. He was brought in by his mother today because he's just not responding. The nurse has already rushed him into the recess room. As you can see, he has a non-rebreather mask on, and they've started the initial resuscitation. What do we want to do next with this patient? What do you want to know?
You guys were assigned to resuscitations today in the emergency department. So what do you guys think about this patient?
Start with an MRI, go bold.
You can jump straight to MRI. I'm not sure if it's going to be ready, but what's some of the first things you want to do? There's no right answer, there's no wrong answer. It's just, we'll see what happens. More history. Okay.
More history, perfect. So good first step. Unfortunately, it is really hard to get a history because the mom is crying and the patient is unresponsive and 6 months old. If you're able to get a little bit about the prenatal and perinatal history out of the mom, you find out that he's pretty much been a healthy 6-month-old up until this point. He was born at term, no complications. Been a little more fussy maybe over the past couple of days, but today he was definitely just fully out of it. Is there anything else that you would like to know on history when you have a chance to directly ask the parents? Yeah.
Vaccination, immunization.
He is fully vaccinated. At the back?
How have they been eating, going to the bathroom?
Sure. So decreased appetite over the last couple of days, but urine output seems to be about normal. He's a little constipated, mom thinks.
Anybody else sick in the family?
No known sick contacts.
Fever?
Afebrile, and he's been afebrile while he's been in the emergency department as well.
Any evidence of pain?
Mom doesn't think so. We don't think that there's been any pain. At the back?
Has this ever occurred before with this job?
No. Previously, well, never had anything like this at all.
Meeting?
Pardon?
Meeting?
A little less than normal, but still seems to be voiding okay.
Travel?
Nope, no travel.
Good question.
Yeah, good question. Mom doesn't think he's got into anything. She's not 100% sure though. The back?
Any rashes?
No rashes over his body that mom's noticed, and none on your physical exam either. I'll give it away. So let's switch over to the physical exam. You start going over the physical exam, you notice his vital signs. He seems hemodynamically stable. He's not completely unconscious. He is responding to pain, but only minimally. You notice some low tone, but he has good cap refill. His pupils are equal and reactive. There's good air entry in his lungs. His belly seems soft and benign, and no rashes on his body. What are we doing? We have a very sick, undifferentiated patient in front of us.
Blood work labs?
Blood work, excellent choice. So blood work, what do you guys think of the blood work? So it looks pretty good, right? I mean, doesn't really have a high weight count. His electrolytes seem fine. His lactate's a little bit elevated, you notice. There's maybe a mild acidosis going on as well. Might be due to the lactate, but nothing else really seems to be too out of place. But his glucose was normal there. What if it was 1.8? What do we do when a child comes in and they are hypoglycemic? I think we all know what to do when an adult happens, but what do you do when that child comes in hypoglycemic?
I know outside of the hospital, they have like a specific case that they can give them, but I don't know about in the hospital.
Yeah, so that's right. Outside of hospital, you definitely have some options for oral sucrose. Definitely don't want to be doing oral sucrose though when they're not responsive because there's an aspiration risk. So in pediatrics, we have something called the rule of 50s. We basically want 50 components of dextrose into the child. So if you're giving D10W, that means that they're getting 5 mils per kilo. If it's D25, it's 2 mils per kilo, and if it's D50, it's only going to be 1 mil per kilo. We, as the kids, almost always use D10W. What we have available at the bedside, it's what we're comfortable with and our nurses are comfortable with. And also for these really small kids, unlike with an adult, to give an amp of D50 is really, really viscous for their small veins. And these are the kind of concentrations we usually want central access for, like a central line. So if his glucose was low, we would be giving D10W, 5 milligrams per kilo.
But his glucose was normal.
But his glucose was normal.
So that's not helpful.
So,
Useless.
that was great. All right, so sick patient in front of you. Besides calling for help, we've done labs, they seem okay. Physical exams aren't really throwing too much out at us.
What would you guys like to do next? Talk screen? Cool.
Talk screen.
That's a good choice.
Yeah, definitely. If we're thinking about a differential for decreased level of consciousness in a child, the talk screen should be up there. Accidental ingestions, if parents left some edible marijuana out, if they got into somebody's methadone, if they got into Benadryl, or the parent gave them too much Benadryl from a rash, all of these can lead to decreased level of consciousness. Fortunately, our patient's talk screen is negative. We don't need to worry about it.
Urine?
Urine, sure. Urine dip is negative. Not too much going on there.
Chest X-ray?
Great. Chest X-ray. So in our resus room, we are actually fortunate enough to have an X-ray arm right in there, so we are able to get stat X-rays. And because you said chest X-ray, now you need to interpret the image that you ordered.
Bowel obstruction.
So,
Who ordered the chest X-ray? This table here?
yeah, that table.
Yeah, perfect. So,
The teacher in the back of the room ordered the chest X-ray.
oh, is that you? There you go.
So Denise is
chest
gonna,
X-rays.
That's
That's
okay.
family practice.
Denise is
If
gonna
you
interpret the
see
chest X-ray
anything
for
that looks
us.
out of place, or, well, you're not just sort of draw it with your finger. It could also be normal.
I don't know. Thankfully, I get a piece of paper that has interpretation on it.
Radiology lead will be ready in about 24 hours.
Anyone else want to take a stat?
Somebody can read
This could also just be normal.
Is the median stand a little bit large?
Is the median spine a little bit large? So you're wondering this?
Yeah, exactly.
And I think if this was an adult X-ray, it probably would be. But what you're probably seeing here is a little bit of finite shadow that's just making it seem a bit enlarged. So that's actually normal.
Kid chest X-rays are really tough to look at. Compared to adult X-rays, they tend to have gunk in their lungs, they tend to have that wide-looking mediastinum. So kids' X-rays in general, I find are much harder to interpret than an adult. I would call this X-ray more or less normal. You might make an argument that there's maybe a little something going on, kind of on the right sternal border. Maybe, but I don't think it's anything that would account for this patient being unconscious. I think there's likely maybe some viral streaking, maybe he had a cold at some point. Maybe. Chest X-ray, more or less okay. Next step,
Abdo X-ray.
abdominal X-ray, excellent choice. So, whoa, abdo X-ray, we get one of those. What do you think?
Bowel obstruction.
Do you want to circle what you see?
So there's air fluid levels.
Awesome, air fluid levels. There's a sign of obstruction.
Great.
You're totally right. Why is the kid obstructed? So we're kind of putting some pieces together. What's on our differential for a child? Decreased level of consciousness who's having some signs of bowel obstruction. How do those fit in? What do you do next?
Intestinal malrotation,
So how would you find out?
Air enema.
You do an air enema diagnostically?
You could.
You could. CT? We actually don't have an abdo CT.
We have a
but
head
did-
CT.
We accidentally CT'd his
We thought
head.
maybe someone wanted a head CT. We didn't do an abdo CT, but it was normal.
So if we're thinking about a differential on a pediatric patient with decreased level of consciousness, a head CT would totally be reasonable in a lot of cases. On that differential, you should be thinking about things like non-accidental trauma. You have to be aware of it or you're going to miss it. Shaken babies can present with decreased level of consciousness. Tumors and intracranial pathology do happen in children, and that can definitely cause decreased levels of consciousness. DKA, if they're having cerebral edema causing herniation, can cause decreased levels of consciousness. A CT of the head is not unreasonable. CT of the belly, we really shy away from in kids because of the radiation. There's usually lower radiation methods that we can go for. We got the ultrasound. So you phone up the radiologist and you ask for your ultrasound, and they say, all right, we'll send them up in about 20 minutes. And you're like, but this kid is floppy in front of me. I don't wait 20 minutes. So you pick up your ultrasound probe, being the proficient PA. Did I mention that one of my interests was point of care ultrasound?
You did.
I did. Okay, so you pick up your ultrasound probe because you're a proficient PA, and you see this on the screen. Does anybody here review ultrasounds or do any point of care ultrasound?
Only on prenatal patients.
Prenatal patients.
So I'm looking for a human, we're not human.
You definitely see a human, it's confirmed. All right, so maybe I'll get Dr. It
Ball. It looks kind of like a ball. I can't probably. The circle in the middle.
Circle. Circle is good. Circle is good.
Do you want to point out what you're seeing, or just kind of draw it?
Totally. So that is completely right. That is what we would call the bullseye sign. If you think about it, it's kind of bowel inside of bowel. It looks like a bullseye. You're seeing a pattern that doesn't look normal. This is not what we're interested in, and this is not what our patient has. Sorry. So this looks to me like a small bowel intussusception, which are normally asymptomatic. We can tell because on ultrasound, this is only about 1 centimeter, and the intussusceptions that we might be interested in, they're about 3 centimeters. Fortunately, this is not what our kid has, and we're not left in limbo any longer. This is what our kid has. This is the giant bullseye. Ultrasound is nearly 100% specific and sensitive for this. This is definitely a bedside test that PAs can learn to do. You guys all appreciate that giant, what the heck is this in the belly? Yeah, so we've arrived at our diagnosis. This is intussusception. And I think the table back there already mentioned something about an air enema, so that's also definitely the pathway we're going down. So what is an intussusception? I kind of alluded to it a little bit earlier. There's 2 types of intussusception. There's small bowel, and then there's the ones that we are interested in when we talk about intus. Ileocecal or colic. So that's where the small bowel is telescoping into the large bowel, or the large bowel is telescoping in on itself. About 20% of intussusception patients have a cause that we can identify for their intussusception. Things like HSP, which cause bowel edema, and then it gets caught. Things like lymphadenitis or Meckel's, again, things that get caught as the bowel is doing its normal peristalsis. So for reduction, we usually use air enema. You can also use barium enema, but air is definitely the usual go-to. There are some things that we need to consider for this patient though, because the risk with air enema reduction is a perforation. And this patient is at a slightly higher risk of perforation. So factors that make this patient at increased risk, they're about 6 months. We know that under 6 months of age, kids are more likely to have a perforation with a reduction. They had signs of obstruction. We saw those air fluid levels that you pointed out. And we know that signs of obstruction are also potentially at risk of perforation. If we had reason to think that this patient had a pathologic lead point, maybe they've had some bruising and swelling up of their legs, and we were suspicious of HSP. Patients with a pathologic lead point are also at increased risk of perforation. Intussusception should really be suspicious for. Usually most of it occurs between 3 months and 3 years. Outside of those age ranges, it can definitely still happen. It can even happen in adults. But outside of those age ranges, you should have a heightened suspicion for those pathologic lead points.
All right. So this was a really tricky case. It's a real case because the kiddo didn't come in with episodic abdominal pain, didn't come in with vomiting, normal abdominal exam. And I think one of the key points to intussusception, or to kids who have a decreased level of consciousness and everything else is negative, is to never forget about the belly. And that for some reason, there are case reports, and we've seen it a few times, and Jordan's seen this as well in our emergency department. Kids sometimes come in just really flat. We have no idea why, and we forget to look at the belly. And with Jordan's skill set with doing point of care ultrasound, which is pretty easy, just sort of scan through the abdomen, he's able to find an intussusception there, and that totally links to the reason why. So sometimes the only presenting symptom of an intussusception is decreased level of consciousness.
It's not the classic triad of belly pain, lump in the right lower quadrant, and red currant jelly stools. That is very rare to get to that stage, and if they're in that stage, that bowel has been intussuscepted for a long period of time and is probably ischemic.
Perfect. So thank you for handling that
No problem.
so beautifully. Let's go back to Hannah. Okay.
Just a question on that last one. What's the sensitivity for point of care ultrasound for this OA and specificity for that?
Good question.
They're both nearly 100%.
They are, okay.
Yeah.
In the hand of the person who's doing it, for example.
Operator dependent,
Yeah.
but yes, in the hand of an experienced person, they are nearly 100% each.
Yeah, it's pretty good. So here's Hannah. Let's get back to Hannah. We probably spent, 30 minutes in the resuscitation room trying to sort out this complex kid. Now that we've got some time, we go back into the room and let's chat about Hannah a bit more. So we already know her past history. She's been feeling a little bit unwell. She's got this nagging throat pain. Her mom's like, it's another anxiety attack or whatever. Let's just calm her down, give her some Advil, send her home. But now when we come back to the room, she looks a bit different to me. Does anyone notice she looks a little bit different? She's got this pale, sort of grayish look that kids sometimes get when they're unwell. So that's a bit of a red flag. And if you look at her vital signs, this looks a bit off. So her heart rate's now 140, but she doesn't look overly anxious, so she's not sort of fidgeting in the bed. She doesn't look like a kid who's having a panic attack. She's actually rather still, almost, with this heart rate of 140. She's breathing a bit faster now, 38, and she's a bit hypotensive for her age. So, skinny 15-year-old girls, not unexpected systolic blood pressure in the 80s, but now this is 78. So it's starting to concern me a bit more. And her saturations are 93. It's not super low, but it's definitely not normal for a 15-year-old girl. So something is going on. And I want to know, what should we do next?
Labs.
Labs. Perfect. What do you think about the labs?
Thoughts? Do these look normal? Do they look fine? CRP is high. Yeah. CRP
This is crazy high.
super.
CRP is 248, so that's really high.
Normal ranges look less than 1, by the way. Just so we know.
Yeah. So that's pretty high. What else are you noticing on here?
White count.
So it can, especially in the newborn age. I would say that when you're seeing CRPs 50 and above, you should start thinking pretty hard this is going on. Yeah. And even below that, a CRP of 20 could still be indicative of something. For our newborn query sepsis workup pathways for partial septic workups, we use a CRP of 20 as our cutoff. So if a newborn comes in with a fever, they seem pretty well though. We're doing a partial septic workup. We do blood work, a urine catheter. Urine catheter is negative. Blood work looks okay, but the CRP is 25. That in and of itself will buy that kid a full septic workup. So it depends on the age, but I would say 248, you're just, whoa, okay, this is not an anxiety attack. I'm starting to Because this girl's actually unwell. What do we make of the rest of this though? So her white count is up. Sure, kind of fits in line with the CRP, so we're kind of expecting that. Her hemoglobin's all right, it's a little bit low. Her electrolytes seem okay. But her creatinine is 102, so that's actually pretty high for a 15-year-old girl as well, with no past medical history of any renal impairment or any issues. So that's a bit bizarre as well. Why is her creatinine really high? Why is she tachypnic? And why is she tachycardic and then has this high CRP? Any just thoughts right now?
When they say she was unwell, upper respiratory tract infection, pharyngitis.
Yeah, she was just constantly feeling feverish and complaining of this throat pain. And again, these are real cases, so this is exactly what this girl told us. Say that again?
Train of thought was going to go like group A strep, that's big.
Group A.
Yeah, exactly, totally. And it could be like a glomerulonephritis associated with a group A strep infection. That's why your creatinine is really high, potentially. It's definitely high up on the differential. It's not the differential, it's not the diagnosis stage, but it's definitely high up on that. What would you guys like to do next?
Physical exam?
Okay, so physical exam, just ask me what you'd like to know.
You look in her throat.
Yeah, so when you look in her throat, tonsils are a little bit large, but they're not these huge, swollen, enlarged tonsils. There's no exudate on them, and there's just a little bit of redness back there. So you were kind of expecting something a bit more dramatic than what you're seeing, but just a little bit red. So you do a strep and do the rapid strep and send it off, and the rapid strep actually comes back negative.
Lung sounds.
Lung sounds. So she's tachypnic, and you're noticing that, but there isn't really like a work of breathing to her tachypnea. So I don't know if you guys have seen that, where just breathing a little bit fast, but they're not working hard. So they're not having tracheal tugging. They're not like your asthmatic, where there's intercostal indrawing or subcostal indrawing. She's just breathing a bit fast. When you listen, there's actually good air entry throughout all locals. So again, it's something you're like, it's not really fitting to get a really nice thing.
Any skin rashes, petechiae, or?
Good question. No rashes right now.
Heart
Or she
sounds?
did develop rashes later in her revision, but no rashes.
Heart sounds?
Heart sounds. So she's got both her heart sounds. You're hearing maybe there's like a S4 type sound. Like there's maybe like an extra little thud that you're hearing intermittently, but there's no big murmurs. It sounds fairly normal, except it's fast.
Lymph nodes?
Lymph nodes. There's a bit of lymphadenopathy in the neck, small, and when you're feeling her neck, she reports that she's tender. She's pretty tender in the neck.
Is there spleen enlarged?
She does not have splenomegaly, no.
Any neck stiffness or neurological deficits?
No neurological deficits, but that's a good question.
For MSK exam, any joint pain, muscle pain?
Good, totally normal. Yeah, so normal abdominal exam. Yeah, no renal angle tenderness either. What were you thinking with the joint question?
Oh, like a reactive, like arthritis or something like that, or
Like some type of like rheumatological
Yeah.
manifestation? Yeah, totally. And that could definitely be how some of these kids present in their teenage years with like a JIA type picture.
I know they're not great tests, but the courage and the
Yeah, so when we moved her neck, she reported that it was a little bit tender, but not in that like meningitic type way. So she, excuse me, she didn't have neck stiffness posteriorly, and it was just that like when you were feeling in and around her neck here, she just reported that it was sore.
Thyroid exam's normal?
And the thyroid was normal. Yeah. Any other tests that you guys want to do?
EKG?
Good question. So just as a bit of a reminder, and this is super basic, but ECG, so different parts to it. You've got your P wave here, obviously. You've got your Q wave there, R, and then S, right there. And your T waves here. This is a normal ECG, so we just take a quick look. This is what we would expect to be normal. Sometimes in kids you get a bit of T-wave inversion here, but notice that you're not getting that T-wave inversion diffusely throughout. So this is her ECG. Just take a minute to take a look at it, and even when you look on the iPad there, circle anything that just looks off. We don't have to make a diagnosis from this. Even when I look at ECGs, it's not that I necessarily know everything that's going on, and I'm not a cardiologist, but definitely having the skill set to recognize when something's off so that you know to spend more time looking at it and figuring it out.
So we see some widened QRS complexes in V1. Prominent T-wave inversion in multiple leads. Yeah.
Do you want to circle some of those just so we can see?
We are actually circling. Oh.
Ah.
Try again. And we have to walk up to the front.
So it sounds like you were noticing leads.
Yeah.
Perfect. Anything else that you noticed that's a bit abnormal?
Is that a big Q wave in 3?
In 3 here? Yes, that's awesome. There's a Q wave there. Pretty big, so that's not normal. So we didn't see that in our normal ECG pattern.
We got the tombstones here.
Tombstone pattern.
Back up here. And then also if you look, so here you've got your P, Q, R, and then this big S wave here in lead 1. So that's a bit abnormal. And again, when I'm looking at these things, I don't necessarily jump to diagnosis, just kind of write out what's abnormal. So that S wave doesn't look quite right, the Q wave doesn't look quite right, and this T wave inversion here also doesn't look quite right. And if you look at where you circled your T-wave inversions as well in the lateral leads, it's over V1, V2, V3, which is kind of the right side of your heart. So that piece is telling us that the right side of her heart seems a bit stressed for some reason. We don't know quite why right now, but maybe there's something to look at there. And then you've also got this classic pattern of something called S1, Q3, T3. Have you guys heard of that before? Yeah. So I'm hearing PE. So yeah, maybe she has a fever. So I don't know, like, and then what's with the throat pain? Like, how does that all piece together?
Strep, right-sided vegetation through a clot causing PE.
Totally. That could totally be what's happening. And she had a strep throat, and now she's got a bit of an endocarditis, and now she's throwing a clot. Now she's having a PE. That would completely explain. And it's not so